Welcome, everyone. This is Krista Martel with the Well Project, and I am very pleased to welcome you to our webinar, Prep and Practice, Considerations for HIV Prevention Among Women of Color. And we are going to get started in just a minute as people join the webinar, but we are very excited to have you all here. We sent an email out to all the registrants today that if you are able to, and you're joining both by your, if you're joining the webinar both online as well as calling in, we ask that you click on the phone icon at the top of your screen, which will provide you with an audio pin, and it will be a star and a 3-digit number followed by the pound sign. And if you can just press the star sign, the 3-digit pin, and the pound sign into your phone, it'll connect your web screen with your phone number and count you as one person so we can get as many people on the webinar as possible. So thank you in advance for that. Okay, so we're just going to wait a couple more minutes. And as many of you who have participated in our webinars before, as you can see, we have an active chat box, and feel free to communicate with other participants as well as enter any questions that you have about the presentations. We'll be collecting those questions as the webinar goes on, and we'll do the Q&A at the end of today's webinar. The webinar is going to last an hour and a half, and we look forward to your participation today. Okay, I'm going to give it 2 more minutes and then we'll get started. Once again, this is Krista Martel. I am with the Well Project, and we are pleased to be partnering with the Women's Collective to provide you with this webinar today, Prep and Practice, Considerations for HIV Prevention Among Women of Color. Yes, and it's as you're seeing on the chat box, a lot of people are entering where they're from, and that's really great for all of us to see, as well as to show our presenters the diverse crowd that we have on today. So thank you for that. As we've mentioned in our materials, the webinar will be recorded, and we will be providing a link to the recording on our website at thewellproject.org within 2 to 3 days after today's webinar. So if you have any colleagues that are not able to be here today, they'll be able to access the webinar on our website. Okay, so I'm going to get started. Just a few brief words about the Well Project. We are a nonprofit organization with a mission to change the course of the HIV/AIDS pandemic through a unique and comprehensive focus on women and girls. And the Well Project leverages technology to improve health outcomes and increase quality of life for women and girls living with HIV. We do this through our web portal at thewellproject.org, where we host a library of over 100 fact sheets on different topics related to women and HIV that are regularly updated and reviewed by clinicians and treating providers. We also have a blog called A Girl Like Me that where we have over 60 bloggers from around the globe who share experiences of living with HIV with one another, and we kind of consider ourselves a global hub for all information around women and HIV, and we feature many partners like the Women's Collective of other organizations that focus on women and HIV and have missions similar to ours. So our focus is to provide accessible and comprehensive information, community support, and advocacy building. And today we are excited to partner with the Women's Collective to provide one of our first webinars that is focused on providing providers with this information and education. Typically our focus is for women living with HIV. So we are happy to have you join us today. So now I'm going to hand it over to Martha from the Women's Collective.
Hi, everyone, and welcome to the webinar. It's very exciting to see such a great participation. The Women's Collective is based here in D.C., was founded by Patricia Knowles in those early days of the epidemic as a private phone line in her home. This was when she was diagnosed as HIV positive and didn't realize there were other women like her because, of course, in those early days, that is not where the focus was. So the phone line transformed into a support group called Coffee House, which she initially hosted in her home. That support group is still going today, still very well attended, and really represents, such a huge need for psychosocial support among women living with HIV. It was incorporated in 1995. And secured its first grants in 1996. So we opened our doors in 1997. And whilst there are many other community-based as well as medical organizations serving women, we are still the only organization that is focused on girls and women of color, providing services that include HIV care and support, prevention, education, as well as policy and advocacy services. Our ED and also now our clients are just a huge force in the advocacy world, still fighting for issues related to women and girls. So very excited to be on the webinar and to be able to do this with support from our HIV STD, it's a long acronym, administration here, HASA, in the district. Thank you.
Great, thank you, Martha. And now I'm going to briefly provide an overview of our agenda for today, and I will let each of our faculty give their own introduction and a brief bio, but we have a very esteemed group of presenters today that we're very excited to have. So first will be presenting is Dr. Charlene Flash, and she will be presenting HIV and HIV prevention among U.S. women, a role for PrEP, and followed by Dr. Judith Auerbach, and who will be presenting about knowledge, attitudes, and likelihood of PrEP use among women of color in the U.S. And lastly, we will have Martha Cameron, who you just heard from the Women's Collective, who is going to be presenting on culturally competent PrEP education for women of color. And so we think this will be a really great overview of...
A presenter has muted the meeting. Your line cannot be unmuted.
Oops, sorry. Can everyone hear me? I just got a little note that there was a muted. Okay, you can hear me. Thank you. That's why I love the chat box. Okay, so yes, we're really excited about the great group and very expert group of presenters we have for today's webinar. And again, my name is Krista Martel. I'm the Executive Director of the WELL Project, and very happy to be here today. So just a quick overview about the webinar. It will last approximately 90 minutes with the Q&A at the end. As I mentioned, we'll be taking questions as the webinar goes on. We'll put them in a queue, and we will pose those to the presenters at the end of the webinar. So please use the live chat box on the left side to enter your questions. And also, as I mentioned, if you're listening to the webinar via your phone, please enter the second audio pin that you will see if you click on the phone icon at the top of your screen into your own phone, which is a star sign, a 3-digit number, followed by the pound sign. Okay, so now before I introduce our first presenter, we're going to take a quick audience poll to just kind of gauge awareness around PrEP. And so if you can just, we'll start the poll now. The question is, how much have you heard about PrEP? And the answers are a lot, a fair amount, only a little, or nothing at all. Okay, so it looks like we have some pretty knowledgeable people at this point. We're going to have the poll open for just a few more seconds, but so far we have about 81% saying they have heard quite a bit about PrEP, with only one person saying that they've heard nothing at all. So we definitely have a group that has some knowledge, so that's a good thing to know. All right, we're going to close the polls now. Thank you. And with that, I'm very pleased to introduce Dr. Charlene Flash from Baylor College of Medicine to give her a little introduction and to present her presentation on HIV prevention among U.S. women.
Thank you, Martha, for that kind introduction. My name is Charlene Flash. I'm an assistant professor in the Department of Medicine, Section of Infectious Diseases at Baylor College of Medicine. And I had the honor of developing and implementing one of the first real-world HIV prevention programs that prescribed to both high-risk heterosexuals as well as men who have sex with men, that was outside of a research setting or outside of a demonstration project, to see what happens in real-world settings, especially in areas of the country that have excess incidence. My research focuses on PrEP perceptions among patients and providers surrounding PrEP attitudes, changes in risk behavior, changes in risk perception, and implementation science. So as I talk with you for the next 25 minutes or so, I'll talk with you first about the epidemiology of HIV in the United States among women, and then we'll talk about whether or not there's a potential role for PrEP among women in the United States. And also at the end, we'll talk a bit about the unique considerations of prescribing to women. So let's start with the epidemiology. So as you consider the estimated HIV incidence among adults and adolescents in the United States, we know that the epidemic among men who have sex with men is at a crisis point in the United States. However, many might not be aware that approximately 20% of infections in the United States actually also occur among women. On this slide, you'll see in the blue infections among men, and both men who have sex with men and men whose transmission risk category is injection drug use. But in the red, you'll see the numbers of people whose estimated HIV incidence are among women, whether they be Black, white, or Hispanic, Latino, and other. Now, as we consider the epidemic in the United States, there are also some interesting considerations as some very pronounced health disparities exist in the United States. First of all, as you think about the female population in general, and we look at that pie chart that's on the right side, we'll see that 64% of the United States population is made up of the United States female population is made up of women. However, in the pie chart on the left, when you look at the proportions that are related to new diagnoses of HIV infection, you see that white women only comprise 18% of new diagnoses of HIV infection. Let's look again at that pie chart on the right. I'll focus your attention on the pink wedge of the pie, and you'll see that Black and African American women only comprise about 13% of the population of women in the United States. However, they make up 62% of the new diagnoses of HIV infection. So we see that there is a pronounced disparity in the United States. This shows us in a different way, in which we see between 2010 and 2014, although there has been a decrease in total numbers of infection, in 2010 there were over 6,000 infections among Black and African American women, and that did decrease to 5,000 new infections, new diagnoses in 2004. However, you can see by the distance between those lines that the disparity is quite pronounced. Also note that the rate of infections among whites and Hispanic and Latina women, as well as among Asians and those of mixed race, has remained stable over time in recent years. Now, why is this even important? As we have made advances in HIV linkage, care, and retention, we note that in the late 80s and early 90s, HIV was considered the leading cause of death in the United States for people between the ages of 25 and 44. With the advent of figuring out the virus and discovering antivirals and disseminating antivirals to at-risk communities, those rates of death plummeted over the next several years. And you'll see that by about 2013, it became the 9th or 10th leading cause of death in the United States for people between the ages of 25 and 44. Now, what we'll notice, however, is that among Black and African American women during that same time frame, though there also was a decrease, HIV still remains among the top 10 leading causes of death, and in fact ranks 4th to 5th among leading causes of death in the United States. When we look at this slide, we can also note on that right-hand column, it shows you the rates of death in populations, and you'll see that deaths among Black and African American women are 17 times the rate of death for white women. The disparity is not just one of race and ethnicity, however. When we look at this map of the United States and you see the numbers of people who are living with HIV in the United States, you'll see that in those darker purple pigmented states there on the East Coast and in the South, you'll see that we have the highest rates of people living with HIV. Well, we've talked about new diagnoses decreasing slightly, so perhaps things have changed as we move forward. So in our next slide, let's look at the rates of new diagnoses. So people who are newly found to have HIV infection, and you see that there are still disproportionate burden of new diagnoses clustered on the East Coast and in the southern portion of the United States, with the highest rates in DC. Now, as you think about how this is happening and what are the ways in which HIV is transmitted amongst these populations, you'll notice that the predominant mode of transmission in the United States for women is heterosexual contact. But again, there are disparities in what transmission risks occur amongst what population. On the right, you'll see that 75% of transmissions are attributed to heterosexual contact, but fully nearly a quarter of transmissions among white women are attributed to injection drug use. As you move across the slide to the left, however, you'll see that the proportion of new transmissions that are related to injection drug use decreases. And in fact, among Hispanics and Latinas, it's 13%, and among Black and African American women, it's only 9% of transmissions that are related to injection drug use. So as we think about the risk factors for HIV in the United States, we think about the fact that the majority of transmissions in the U.S. is via intercourse, and that there's a very high prevalence among Black women. But one thing to note, that this prevalence can be disproportionate to their actual engagement in traditional risk behaviors, meaning that although there are a lot more Black women in terms of the women with HIV that are infected, this doesn't necessarily link up with their number of partners or the fact that they are or are not using condoms. In fact, I often tell people that I call this the good girls with bad boys strategy, where you'll find women who've had 1 or 2 lifetime sexual partners, and because of their sexual mixing pattern, the group of people within their community that they're choosing to have relationship with or to have sex with, because that community has such a high rate of HIV, the chances of them choosing a partner who is HIV infected is much higher, even if they only have 1 or 2 sexual partners. And so these women from these communities face a greater risk of HIV infection with each new sexual encounter. Now, although in communities of color, injection drug use itself as a transmission risk is only 9 or 10%, drugs do indirectly influence HIV transmission, as people who are engaged in under the influence of drugs or alcohol are more likely to engage in high-risk behaviors while under the influence. But one thing that cannot be ignored is that there are also multiple structural factors that influence excess rates of HIV in these communities. Poor access to health care, lack of stable housing, limited HIV prevention education, and increased prevalence of other sexually transmitted infections. There are also some biological factors. When a man and a woman have vaginal intercourse without a condom or other protection, the risk of transmission for the woman is higher than the risk of transmission for the man, meaning the woman can catch HIV easier from the man than the man can from the woman. However, one other thing to note is that there are a fair amount of women in the United States who are engaging in anal sex without a condom. In fact, when you talk to some women, and particularly some young women, they will preferentially engage in anal sex because it gets rid of the consideration and the concern about unplanned pregnancy. Or some carry a mythology that anal sex is safer than vaginal sex because you're less likely to catch an infectious disease. If you look over at that cartoon on the right-hand side, you'll see that the thickness of the rectal mucosa is comprised of columnar epithelium, whereas the vaginal mucosa is comprised of several layers of squamous epithelium. So you can imagine that it's much easier for virus to pass through that more tenuous rectal mucosa than the vaginal mucosa. You know, and then as these women try to navigate condom use, some women are afraid that their partner will leave or physically abuse them if they try to talk about condom use. The barriers to condom use are many. There's a personal perception of perhaps being low risk. If you don't have many partners, perhaps you feel like I don't need to use a condom with this one partner I've been with for a long period of time. Is there the desire to conceive? Or are there high partner-related barriers to condom use? So as we think about the excess risk among women of color, and we think about these barriers to condom use, we consider what else do we have in our toolbox, and PrEP becomes a potential option. So what is PrEP? PrEP is pre-exposure prophylaxis. That is the use of a pill taken on a daily basis to prevent HIV infection. At present, there's only one FDA-approved drug that is co-formulated tenofovir and emtricitabine, and in clinical trials, it has proven to be 44 to 67% effective if taken as people normally take this, which is missing doses upon occasion. Now, if taken perfectly, it has demonstrated 92% efficacy in clinical trials, and in some real-world implementation data has actually demonstrated 100% efficacy. Early on in the rollout of the research results for PrEP, there were some initial trials I'll talk about a little bit later that gave us some pause as to whether or not PrEP would be efficacious among women. But we do have two trials, the TDS2 CDC-funded randomized trial among men and women in Botswana that were randomized either to PrEP or to a sugar pill, and we found there that there was a 63% reduction in the risk of HIV acquisition. So that was one of the first signals that PrEP could work among women because there were women represented in that trial. In the Partners PrEP trial, nearly 5,000 serodiscordant couples, so one partner is known to be HIV positive and the other is known to be HIV infected, again recruited from Africa, from Kenya and Uganda, were randomized to either tenofovir alone or to the combination pill that we consider PrEP now in the United States, or placebo. And we found that there were between 62 and 73% fewer infections among people who are randomized to the active agent. Now, although in these trials we also counseled people to utilize condoms and to utilize things to prevent conception, the pregnancy rate was high, 10.3 per 100 person years, with no difference between groups. And so we see that even represented in these randomized trials, what's reflected is what happens in the real world, where if people are having intercourse with condoms, that pregnancy rate shouldn't be as high as that. And so we can see, despite giving them out and counseling people, that they're not always used. Now, in terms of what to do, the CDC has issued guidelines. These guidelines are from 2014, and though much of the attention in the United States has been surrounding PrEP use among men who have sex with men, you'll see that the guidelines also include guidance on how to prescribe among heterosexual men and women and injection drug users. The guidelines are, I would direct you to them as they talk about how do you determine what people are potentially at risk, who is clinically eligible, how do you write the prescription, what kind of follow-up you need, and then what additional testing is needed to make sure that the person remains safe. So as we dive into this a little bit more closely, let's ask ourselves who are potential PrEP users. So a no-brainer are people who have a known partner who's HIV infected. But not everyone who has a known HIV infected partner is necessarily someone who has to be on PrEP. The people who we want to emphasize that PrEP might be a strong option for them is if they're in a partnership that they indicate they don't always use condoms, or when their HIV positive partner's viral load is not consistently undetectable. Also, people who have had a recent history of transactional sex, meaning that they've traded sex for housing or drugs or money or whatever else. People who have a bacterial sexually transmitted infection, gonorrhea, chlamydia, syphilis. HIV walks together with these things, and so when you encounter patients who've had one or more of these, PrEP should be part of the conversation, because this also potentially reflects high-risk partnership and inconsistent or non-condom use. Also, people who are dependent on alcohol or drugs or have been recently incarcerated, or women who have a high-risk partner. Remember, we talked about these relatively apparently low-risk women, but are in partnerships with very high-risk male partners who may be having sex with men, or may have multiple other sexual partners, or may be injecting drugs. And even though the individual woman is not engaging in those activities, her partner might be and be putting her at excess risk. PrEP empowers women and allows them to control their risk of getting infected with HIV without relying on their HIV-positive partner to keep their viral load undetectable, or relying on their own ability to navigate condom use in a private and a safe way. Now, there are some unique considerations when prescribing to women as opposed to men. First of all, when you think about how long does it take for the medication to get to an appropriate level within the cells of action to afford protection, we see that in the rectal mucosa, so when people are having anal sex, if the area of exposure is the rectum, it takes only about 7 days to achieve appropriate levels of drug there. However, if someone's primary risk of transmission is vaginal intercourse, it takes as much as 20 days to achieve appropriate levels in the cervical and vaginal tissue. So, though 5 to 20%, depending on what literature you look at, of at-risk women are having anal intercourse, the primary mode of transmission for many women is vaginal intercourse, and it takes a longer time to get to appropriate drug levels. So as you're counseling women, it's incumbent upon the provider to really encourage adherence amongst these women. And also, the medication is just less forgiving amongst women than it is among men for missed doses. You know, this adherence assessment and adherence support and adherence counseling, it preferentially needs to be in a non-judgmental way. So not, you really should be taking your medication or you're going to get HIV, but really working with individual women, trying to determine what are the barriers to them being successful in taking the medication on a daily basis, and what are some supports that can be put in place to help them be successful. This non-judgmental adherence support and this ensuring that the woman herself finds PrEP an acceptable addition to her toolkit of prevention is really important and pivotal. As we think back on some of the previous trials where PrEP seemed not to show efficacy, it was among women who did not feel themselves to be at risk. So though prescribers might believe that PrEP will empower women and are willing to prescribe, PrEP will empower women who believe themselves to be at risk and find PrEP to be a useful and acceptable tool to prevent HIV transmission for them. We mentioned some of these trials earlier, the FemPrep and the Voice trial, randomized trials of 2,000 women in Africa who were in relationships where with more than one partner in the past month and had more than one episode of intercourse over the prior week. And they were randomized to either the combination pill we know as PrEP versus placebo, and the trial was stopped early because there was no difference. Why did that happen? Well, adherence was poor. Why does it appear adherence was poor? Because only 1/3 of the women felt themselves to be at risk. So even if the providers and prescribers can't be presumptive and decide this woman is or is not at risk, the woman has to take on ownership of the fact that something additional is needed to protect her, or she won't be successful being adherent. As we think about what are some of the real-world considerations, we need to think about real-world efficacy in the context of other medical problems and comorbidities, in the context of real-world adherence with all the other things that women have going on in their lives, and also long-term drug safety considerations, where the most common side effect is mild and inadvertent weight loss or some mild nausea and vomiting that in my experience only lasts for 2 or 3 days unless the woman has another medical problem that kind of makes her prone to symptoms such as nausea and, abdominal pain. The most common lab side effect is a bump in the woman's creatinine, a change in her renal function. That usually happens fairly early on, so it's important to have them come back to check that renal function. And for many women, you can find other reasons, things that can be adjusted in their lives that enable them to continue forward. So are they taking lots of non-steroidal anti-inflammatories or pain medications? Is the woman taking ibuprofen 6 times a day, for example, and that needs to be addressed so that her kidneys can handle PrEP? Or is the woman just dehydrated, not really thinking about the need to kind of keep her kidneys hydrated? So things like that can be addressed. Or is her blood pressure needing tighter control? The other thing that we really need to think about for women, and has honestly not been well studied in the United States, is this 1% loss in bone mineral density at the total hip and femoral neck. Now, though rates of bone fractures were shown to be no different, we don't have long-term data in women who, as they age, are at higher risk than men of having decreased bone mineral density. So two additional considerations as I close my segment of the webinar are this idea of utilizing PrEP so that women can safely conceive children even though their sexual partner is known to be HIV positive, but they want to ensure that their babies are not infected. Now remember that a baby can only become infected if the mother is also HIV positive. So protecting that mother from infection becomes very important. Now there are many options on ways to safely conceive. However, PrEP is an additional potential tool to help women conceive babies that are HIV negative safely. PrEP, when used in this way, should begin 1 month before attempted conception to make sure that you have the appropriate drug levels on board to actually provide protection. And generally, I recommend that you continue at least 1 month after successful conception. And then, this is what you'll see in CDC guidelines. But to be honest, I'll have to tell you that in my own counseling of women, after you've told the women, listen, I want you to have condomless intercourse so that you can conceive, because with a condom it's not going to work, you're not going to be able to make a baby. Sometimes it's hard to go back to using condoms all the time after you haven't been using condoms for some time in the attempt to conceive. And so for those women, because the time frame of pregnancy is permissive for HIV infection, I do recommend that they continue PrEP during the period of pregnancy to continue that protection so that they don't become infected with HIV after safely conceiving, and then during the pregnancy get infected with HIV. Additionally, breastfeeding, we don't have a lot of data about the details of PrEP safety for infants exposed during breastfeeding in terms of women who are HIV negative who are taking this combination of medications while breastfeeding. However, we have years of data of infants born to women that have HIV, that have been on this medication, and have had exposures through their breast milk that suggest that there is limited drug exposure to the infant. In the United States, we recommend that women who are HIV infected do not breastfeed, but internationally that's not the case. And so that international data has been very elucidating in terms of what happens to infants whose mothers are breastfeeding them and are also on these chemicals, and what happens. So, final thing to think about as I close out my segment is that there are many future PrEP formulations that will come down the pike. There are injectables and a topical gel and a ring and a patch and an implant. These other agents are currently being investigated. However, today we only have one FDA-approved agent. But as we pay attention to how to disseminate it to at-risk populations, as we set up the needed systems to address barriers, enhance awareness, and get it to the people who are most at need, we will pave the way as these additional tools become available and really hopefully make a difference in those initial epidemiological slides I showed at the beginning that show disproportionate risk in communities of color, and 20% of infections occurring among women, a population that should not be ignored in terms of HIV as we move forward. With that, here are some selected references. We'll have more extensive references on the slides that you can download after the webinar. I can be contacted at flash@bcm.edu. If there are additional questions for people who want to engage in our prevention program, the contact phone number is listed there as well. Thank you for your attention.
Thank you so much, Dr. Flash. That was a really wonderful overview of PrEP and PrEP in women and all the different considerations. So we really appreciate your fantastic presentation. And next, I am also very excited to introduce Dr. Judy Auerbach, who is with the University of California, San Francisco, and also we are fortunate enough to have Dr. Auerbach as part of our board of directors and has been a longtime supporter and of the WELL Project, as well as an active member of the Women's Research Initiative on HIV/AIDS, which is a program of the WELL Project. So with that, I will hand it over to you.
Great. Thank you, Krista. This is Judy. Can you all hear me, or can anybody hear me?
Yes.
Just to confirm it's working. Okay, thank you. So hello, everybody. It's just wonderful to see who all is on this webinar and the dialogue that's going on. Happily, there are people who are participating, who are answering many of the questions that otherwise would be posed to those of us who are presenting. So we thank you very much for that interaction. So I am a sociologist by training, and I've worked for over 25 years at the nexus of HIV science and policy for a number of governmental and non-governmental organizations. And I now work mostly as an independent consultant here in my lovely home office in San Francisco. And as Krista mentioned, I also have an appointment as professor in the School of Medicine at the University of California, San Francisco, where I'm affiliated with the Center for AIDS Prevention Studies, or CAPS. And as she mentioned, I serve on the board of the WELL Project. With respect to PrEP specifically, I've been working for a number of years with numerous organizations, including the National Institutes of Health and their Office of AIDS Research, AIDS United, the San Francisco AIDS Foundation, the WELL Project, the San Francisco Department of Health's Capacity Building Assistance Program, and the U.S. Working Group on Women in PrEP, just to name many of the key players, at kind of all facets of PrEP, education, information, advocacy, and so on, and research, of course. And importantly for this presentation, I also worked very directly with AIDS United in conducting and analyzing a focus group study on U.S. women and PrEP, and I will be mentioning that momentarily. by way of introduction, as you heard from Dr. Flash, there have been a number of large-scale clinical trials looking at PrEP efficacy, and specifically Truvada for oral PrEP. But none of those large trials that have been published and presented has included U.S. women. Even with that, and based on a couple of the studies that Charlene mentioned that involved women elsewhere in the world, the FDA did approve the use of oral Truvada for PrEP among U.S. women as well as men in the summer of 2012, even though at that time we knew very little about what U.S. women actually knew or thought about PrEP for themselves or others. And since about that time, in fact, even before the approval, there have been a number of studies that ultimately were published and presented that were trying to ascertain what U.S. women who might be defined as at risk for HIV infection in particular know and think about PrEP. And of course, the notion is that findings from these studies should help inform PrEP implementation programs and clinical practice, because as we know from our large-scale clinical trial research experience, you can build it, but they may not participate, so to speak. So we want to make sure that things are actually relevant to the people who we are concerned about. So what I'm going to mention today is a number of focus group studies, and there were a couple of surveys and one interview project that have ascertained attitudes and knowledge among relevant women about PrEP in the U.S. And we'll identify some common findings and themes at the end. So, and as you will see, I have put the reference on the slides. You'll be able to get these slides after the presentations, after the webinar, and this way you have the full citation along with the summary information about it. So I apologize if the slides appear a little busy, but I was trying to give you all summary information in one place. So the first study I want to mention was a focus group study conducted well before even the first clinical trial data from IPREX, the first published and presented PrEP study, which was among gay and other MSM and a few transgender participants, were released. So this was a focus group study conducted by Dawn Smith and colleagues in Atlanta, and it took place as early as 2009. That involved African-American young men and women aged 18 to 24 who were determined to be at risk for HIV infection. And they included 8 mixed gender and 2 gay or other MSM-only focused groups. And in the mixed gender groups, young women were about 60% of the participants. So this was a focus group of 35 women for our purposes. And the key findings from that conversation, from those focus groups, were that the participants reported substantial interest in PrEP, and again, this is before clinical trial data outcomes were available. And they identified the core issues militating perhaps against PrEP or the cost, how effective it actually is, and how easy it would be to access services and the medications. They also mentioned low perceived susceptibility to contracting HIV, so that's that low risk perception that Charlene talked about. And some expressed concern about the ability for themselves and others to take a pill every day, as well as concern about others' perceptions about someone taking medication, because this medication is the same as that which is used for HIV treatment. So one might be identified as HIV positive, and there's a lot of stigma that's still associated with that. And what was also important is that the majority of participants thought that PrEP wouldn't change their condom use practices. In other words, those already using condoms would continue to use them, or they thought it was important that people continued to use condoms, particularly for other STI and to some degree pregnancy prevention. A second study, which was conducted by our very own Charlene Flash and her colleagues, was involving 5 focus groups with 26 black women aged 18 to 50, recruited from a primary care facility and its affiliated HIV testing sites in Boston. And that took place January to March 2012, which was before, after some trial data were out, but before Truvada was approved for PrEP in the United States. And their key findings included that a majority of women did express interest in PrEP and that they mostly preferred pills rather than a gel, which at the time were the 2 methods most under study. They also were concerned about cost. Younger women were more open to considering using combination approaches, that is a pill as well as condoms, and they would be more open to different kinds of administration of PrEP. Some were not interested in using PrEP at all, and it's important for us to acknowledge those people, in part because of their mistrust of the pharmaceutical industry. They were concerned they just want to make money, and that people, particularly women of color, have been concerned about being guinea pigs in studies because of their historical experiences. In this study, participants did mention a preference for daily dosing as opposed to intermittent, which is something that was being explored at the time, again, because of this concern about whether people could take a pill or would want to take a pill every day. There were questions that were being explored in research studies about intermittent use. But these folks said that they prefer daily dosing because they did actually believe it would enhance adherence. And I should mention, fast forward about 4 or 5 years, and we now have data from a very large-scale clinical trial and the study site in Cape Town, the HPTN 067 or ADAPT study, which did show that the daily dosing as compared to intermittent dosing among women in South Africa and in Cape Town was more effective in enhancing adherence and did produce, of course, higher drug levels. I want to mention in a little bit more detail a set of focus groups that were conducted and supported by AIDS United, in which I was very much involved. And the findings from these focus groups were presented at 2 international AIDS conferences and then published in a journal, AIDS Patient Care and STDs. And what we did was have 2 rounds of focus group studies. One took place right before PrEP was approved for use in the United States, and the other took place right after, soon after PrEP was approved. And we wanted to, again, ascertain knowledge and attitudes about PrEP among U.S. women at risk for HIV infection in a number of different locales around the country. So we engaged in a formative, qualitative, community-based participatory research project that involved these focus groups, and we defined women at risk by virtue of their social networks, their sex and drug use-related practices, their SES, and other relevant criteria. And the women were recruited by women serving local community-based organizations in these cities, and the focus groups, in fact, were conducted by facilitators from these groups. So in round 1, which was again before PrEP was approved by the FDA, we had 2 focus groups in each of 4 cities, Oakland, Memphis, San Diego, and Washington, D.C., and that was a total of 92 women. All the women in our studies were or thought they were HIV negative. And in round 2, which was right after PrEP was approved, we had a total of 144 women from 6 cities, Atlanta, Chicago, Dallas, New Orleans, Newark. So we have a pretty good distribution around the country. And here is just some basic demographic information so you could see the comparison between the 2 groups, who were mostly very similar, but I did want to mention that for the second round, that is after Truvada was approved for PrEP, we oversampled for Black and African American women because of the disproportionate rates of infection that Charlene presented to you earlier. So we covered in these focus groups a number of discussion topics, which also are typical of the other focus group studies I have mentioned or will mention. And so in addition to initially providing basic information about HIV transmission itself and PrEP, we then started by asking who'd ever heard of PrEP before the focus group, for which women the women participants in our groups thought PrEP might be most helpful and why, what they thought were the possible barriers and facilitators for PrEP, the best sources of information and access to services for it. We did ask if they thought PrEP would encourage more women to get HIV tests, or if that might be a barrier to using PrEP, the fact that one has to have repeated tests. We asked them about their comfort with asking and talking to their medical providers about PrEP. And we phrased a question about the potential impact of PrEP on a woman's sex life, including the use of condoms. We did not phrase it in the sort of typical risk compensation way that the field tends to emphasize, but put it much more generally as how do you think PrEP might affect a woman's sex life, and that included use or non-use of condoms. We'd asked them about how efficacious they thought PrEP needed to be and any other considerations that they wanted to mention about women taking PrEP. For the second round, we added questions about adherence issues and about formulations, because by that time we did have some more clinical trial data that showed that adherence to both oral and film and gel-based PrEP were problematic among women in the African sites, particularly young women. So we wanted to know what American women thought about adherence, as well as the fact that there were now some different formulations and modes of administration of PrEP beginning to be studied, as Charlene mentioned. So we added questions about those to the second round. So key findings looking across both groups, and these are particularly important given that these were primarily women of color and primarily Black women. Women were really dismayed. In fact, they were quite angry that they hadn't heard about PrEP before the focus groups. And they said it was both that somehow information they thought was being withheld from them, but also from their providers and from the people who work at community-based organizations whose services they seek. And they thought if they're not hearing about it, then something is really being withheld from all of us. These women also did mention that they had very good relationships with their primary care doctors and their OBGYNs, notwithstanding, some of their concerns about the medical system. And they did express strong willingness to turn to them for PrEP information and services. I'll say a little bit more about that later. Many women talked about, when we asked about why PrEP would be a reasonable strategy for some women, they said, one of the key issues is just you can't trust men. And so this is a way that women can control their HIV prevention themselves. They did have some distinct ideas about how PrEP might affect their sex lives, including condom use. And they supported a range of PrEP delivery options, including pills, gels, injectables, and vaginal rings, although in our study, vaginal rings were the least attractive option to most women, not all, but most. And they identified key barriers to PrEP uptake as lack of information, cost, side effects, mistrust of the medical system, and mistrust of government. So I only have time to give you some of the qualitative data for a few of the core issues that are particularly relevant for today's discussion. And so first among these, as I mentioned, was the lack of information and kind of anger about that. And you can see from women from Atlanta, New York, and Dallas that there were strong feelings about, in the first case, maybe knowing about PrEP and hearing about it vaguely as something for gay men and other men who have sex with men, but never hearing that it might be something for women. Then feeling like, well, if it's out there, why aren't we hearing about it? Why aren't we getting the knowledge we need about it? And, even when I go and I get HIV prevention information, people talk about how HIV is transmitted, but they never tell me about PrEP. With regard to distrust of men, this was a very common theme, and at the same time, many women talked about having positive relationships with their male partners and engaging them in a conversation about PrEP. That would be a good thing to do, but overwhelmingly there was we love them and we can't trust them entirely. So you can see, people saying that you just don't know what your partner is doing, you don't know if they're being faithful to you no matter what they're telling you. You might just meet somebody, but you really don't know anything about them. And then even when you're married, you don't always know what your husband is doing. When we asked about the impact of PrEP on their sex life, what folks tended to really emphasize was this possibility of having sex with more confidence and safety and without fear that you could enjoy sex again and not worry about blame and not worry about getting infected. And when the facilitator said, so aren't there any negative impacts? They mainly said, the women mainly said, so long as there are no side effects, in this case meaning that the PrEP wouldn't interfere with their sexual activity and pleasure, then they're fine with it. As I mentioned, a lot of women did say they had strong relationships with their individual doctors or medical providers, notwithstanding their overall mistrust of the large-scale medical system. And so we asked them, would you feel comfortable asking your current doctor or provider about PrEP? And a lot of them said yes. But what was interesting is that many said, yes, I'd be happy to talk to them and engage them in a conversation, but I can't be sure that they actually have all the information because, look, I didn't even know about it. So they talked about, as this conversation in Dallas makes clear, the need for the women themselves to be very well educated about PrEP and be able to walk into the conversation with their provider and provide themselves some of the information, as well as obtaining information and guidance from their providers. So they're not entirely trusting that their providers are well aware of PrEP yet themselves. At the same time, there were women who felt like, I'm not sure I'd be so comfortable having this conversation with my provider because there may be a lot of judgment about my sex life as it relates to my need for PrEP. As you can see from this quote from Newark. So another focus group study that I wanted to mention is by Goparaju and colleagues. And actually, I think that should be an L for Lakshmi. Sorry, Lakshmi, if you're on the call. And this was a focus group study that was interesting because it looked at both HIV-negative women who may be interested in PrEP, but also what their HIV-positive counterparts thought about PrEP. So here we're now introducing attitudes among HIV-positive as well as HIV-negative women. And they conducted a focus group study which involved groups segregated by HIV serostatus. So one group, some groups were HIV positive and other HIV negative women. And these are part of the large Women's Interagency HIV/AIDS study, which is a big NIH-funded multi-site cohort study that's been going on for some time that involves matched cohorts of positive and negative women. So in their study, all the HIV-positive women were African American, and there were a couple of Latinas and a couple of other race ethnicity identified women. All but one of the HIV-positive women had used antiretrovirals, and as you'll see, that's relevant for their attitudes about PrEP. So the key findings were that all HIV-negative women had family members with HIV, and they did perceive themselves to be at high risk. So in this study, the women who are involved who are HIV-negative already have defined themselves to be at risk. But awareness and knowledge of PrEP was almost non-existent among all the women, both the HIV-positive and the HIV-negative. And their reactions to PrEP did differ according to their serostatus. So the HIV-negative women were enthusiastic once learning about it, but the HIV-positive women were concerned about PrEP based on their own experience with taking antiretroviral drugs. So in addition, the HIV-negative women thought that combinations of PrEP and condoms was the best prevention approach. So like other women in other studies, they saw PrEP as an extra and a backup protection to condoms because of other STI and pregnancy prevention concerns. But the HIV-positive women preferred condoms alone. And in this study, women thought that sex workers and serodiscordant couples would be the most potential target populations for PrEP. And they were a little reticent to think about PrEP as being appropriate for young women. In addition to the focus group studies, there have been a couple of surveys and interviews that have been published. So I wanted to mention what we've learned from those as well. So this one conducted by Gina Wingood and her colleagues involved a nationally representative random sample of unmarried African American and white women aged 20 to 44 years, and they used a random digit dial survey method that then involved doing interviews with women with audio-assisted interview devices. And what they found were they were looking at the relationship between various social and economic characteristics and attitudes about PrEP, and they found with women with lower educational status, greater lifetime sexual partners, and provider recommendations supportive of PrEP and peer norm supportive of PrEP use were more likely to report potential PrEP uptake than other women. Compared with the white women, African American women were significantly more likely to report potential use of PrEP, and they were more likely to use PrEP if it was recommended by a healthcare provider. They thought they would be less likely to report that they would be embarrassed to ask a healthcare provider for PrEP, and they were more likely to report use of PrEP if their female friends also used PrEP. As in all the other studies, the potential cost for PrEP was one of the key barriers that were identified by both African American and white women in this survey. Another survey was conducted specifically with transgender women in San Francisco, looking at, again, what was known and thought about PrEP use among that population. And this was conducted by Aaron Wilson and colleagues, an HIV behavioral risk survey with 233 trans women who were both HIV negative and HIV positive, 18 years or older, conducted in San Francisco in 2013. Most of the trans women were Latina and African American. And in this sample, again, only 13.7% had even heard of PrEP. More of the HIV positive trans women than the negative women knew about PrEP, as you can see. Of this sample, 149 were HIV negative, and of these, about 45 or 30% were deemed eligible for PrEP based on the current CDC criteria. And you may recall that CDC issued some preliminary criteria that then got more refined to be the ones that Charlene presented earlier. But at this time, they were more limited, and they chiefly, for this population, apply to men who have sex with men and injecting drug users. There were no trans-specific items at the time. So of those who had heard of PrEP, according to the criteria and CDC at the time, only 15% would be candidates. And none of those who would be candidates for PrEP in this survey said they would be willing to use PrEP. Their concerns included the interaction of PrEP with hormones, the general lack of access to health care and social support services, and the dearth of culturally competent health care providers, which I think we will hear more about from Martha, as well as their own distrust of the medical system. And another survey that was conducted in 2013 by Jayakumaran and colleagues looked also at HIV-positive persons' attitudes around PrEP, specifically people attending an HIV clinic in Philadelphia. And this sample included, again, a large proportion of Hispanic, Latino, and African-American participants with some Hispanic, Latino, mixed race, and Caucasian folks. Now, this was both men and women, so it's not women-specific study, but there are some women-specific data that we could ascertain. And of these participants, 164 had a main partner. So these are the HIV-positive people thinking about what PrEP meant for their partners and their own attitudes about PrEP for their partners. So of this whole cohort, again, only 15% had ever heard about PrEP or had previous knowledge of it, but once they were educated about it, an overwhelming proportion, 88.8% of the whole cohort said they'd recommend PrEP to their partners. 84% said that it would give more hope about their future if their partners took PrEP, and an overwhelming 95% said it should be available and free, which is something we heard in most of the other studies as well. 92% said they would want to discuss PrEP with their providers. So this is the positive people saying they'd like to discuss PrEP with their providers. And 77% in this case also said they would be very likely, extremely likely to use condoms every time they have sex if their partner was taking PrEP. So they too see that PrEP is additive to their prevention strategies. Now, I only have a little bit of time, so I just wanted to mention as an example of something emergent, in addition to the focus group and interview studies that have been published, we're now seeing demonstration and implementation projects happening with women and PrEP in the U.S., and one I just wanted to mention briefly is taking place in Oakland, California, focused at Lifelong Primary Care Center, and it's a collaboration amongst a number of organizations and groups, as you can see here, that are providing different expertise and making different contributions to it. So it involves the Gladstone Institute, for example, with basic research knowledge. The Pangea Global AIDS Group is hosting the Community Advisory Board. There's research and evaluation conducted by the University of California, and referral partner and clinical consultation happening at the East Bay AIDS Center and Downtown Youth Clinic. So just very quickly, here is Lifelong Medical Care in East Oakland and the team. And this is sort of typifies their practice. As you can see, the number of female patients and overwhelming participation among African-American women, some getting tested, one is already on PrEP. But what they're trying to do in a study called Crush PrEP for Women is to see about implementing PrEP use for 50 women who are participants or patients at Lifelong Care. So in order to set up the study, they conducted a small focus group with 10 cisgender women of diverse ethnicities who were generally young. And again, like these other studies I've mentioned, found some things that are similar, but in this case, actually the women had heard about PrEP, which was different from all the other studies, and they did support PrEP use, at least in theory. And they'd heard a lot about it from their gay friends and actually knew some people already on PrEP. But they still didn't see women as PrEP targets. So they'd heard about it and they thought it was a good idea, but they still were not feeling like they'd heard much about women as targets, although again, once more fully educated about it as a possibility for women became strong endorsers of it and thought education was real important. They mentioned a lot of the same things that you've seen in the other studies about the key obstacles or barriers to PrEP, the cost, the concern about side effects of the drugs, and they also mentioned ability to have children, which Charlene has described. So looking across all of these studies and this initial implementation project, what we see is general enthusiasm among HIV-negative women, slightly less so among trans women, at least from that one survey, although I think that we're at a tipping point there. We can say more about that in the discussion. Many see PrEP as life-saving. In our focus group studies, women explicitly said that, that this could save lives, and that's why else they were so angry at not having heard about it a few years ago. There are mixed feelings about PrEP among HIV-positive women. Some would recommend it for their partner. Some are reticent based on their own experience of taking these antiretrovirals. As I've mentioned numerous times, women of color are dismayed that they haven't heard about PrEP and feel that some information has been withheld from them. They tend to think that PrEP is a good option for all kinds of women, even if they mention some specific groups like sex workers and women in serodiscordant relationships. But overall, they, in our focus groups, for example, they kept coming back to, well, actually, really any woman ought to be able to take PrEP if she's at risk. But there is still some concern about how well young women would adhere and whether it's the most appropriate thing for truly young women. In addition, most studies have found the same things about the concerns around PrEP, focusing on cost, availability, and potential side effects. There is significant mistrust among women of color based on their historical experiences in research and practice of men, of medical systems, of pharmaceutical industry, and government. But it appears that with education, and if PrEP is information and services are provided by organizations and individuals they trust, then they are quite open to recommending or taking PrEP themselves. They see PrEP as additional protection, not substitute for condoms, and many are in fact eager to talk with their medical providers about PrEP, even though they're not convinced that the providers have all the information, and they feel like they would be active in educating their providers as much as their providers educate them. So with that, I'll close with acknowledgments for a few people who've been instrumental in helping me prepare for this presentation, providing slides, and in supporting PrEP among women. Thank you very much.
Thank you so much, Judy. That was a great overview. I think a lot of really important information that you pulled together. So thank you so much. And I know we're getting close to our time, so I'm going to quickly hand over to Martha from the Women's Collective, who was the catalyst of bringing this webinar together. And so we are really excited to get your perspective and kind of the origins around bringing this together. Martha.
Sure. Thank you so much, Krista. And I want to thank all the presenters. I think this has been really excellent and really part of what we were
Martha?
We just lost Martha.
Yes, we did just lose Martha. Okay. I don't know if she can hear me. So, see that she's on. Okay, hold on one second. I'm sorry. Okay, I'm not sure what happened with Martha's sound, so I'm going to, maybe we can, while we wait for her to come back on, we can pose a couple of the questions that came in earlier on. Some of these had some answers that were coming through, but we'll just bring them up as well.
Hello, can you still hear me?
Oh, yeah, now we can hear you. Okay, great.
Oh, sorry. I don't know what happened there. So, okay. So I wanted to mention that, we received funding from the HIV/AIDS, Hepatitis, STD, and Tuberculosis Administration of our Department of Health here in DC, and I really wanted to applaud them, for the move that they took to actually provide some specific PrEP education for directed at women, because we know that mostly the target has been for MSM that has been largely impacted. But we've been able to, through that, we've been able to engage clients and, really working to provide culturally competent support and navigation to access prescribing doctors, as well as, and I think this is really key, and I'll talk a little bit more about it, is to provide ongoing case management for clients who are prescribed PrEP, but also those who are just generally at high risk of contracting HIV. And I'll explain why this is key. But I wanted to show this slide, which is also from HASA, which really shows this is the district. And I know when Charlene made her presentation, I think she highlighted that we have one of the highest incidences of HIV around the country. But this sort of breaks it down more so even by ward. And there was even a documentary that ended up doing it literally by metro station. And so by virtue of living in Northeast DC, which is Ward 8 and Ward 7, you are, really more than likely to contract HIV just by virtue of, as Charlene says, for your next sexual encounter, it's very likely that you can meet somebody that has HIV. We work in these wards. Right now we're located in Ward 5, and we'll be moving in Ward 7 so that we can be closer to the epidemic. But it's really been interesting when it comes to what we've been talking about in terms of perception of risk and communicating that, because, just by virtue of the guidelines and by virtue of, understanding that you live in a really high incidence or epidemic area, you're at high risk. But because this is where somebody has lived, this is where somebody has grown up, you don't see that risk. This is your normal and day-to-day life. And so we had to also have, in addition to other focus groups that we have participated in, including the one that Judy mentioned, we had to hold our own focus groups to begin to sort of dive in to how we can provide culturally competent education without forcing PrEP on people just by virtue of the fact that we believe that they are eligible for PrEP. And this became really key because nobody has really given that guide. This is the conversation. This is the step-by-step conversation of how you can lead somebody through, helping them to prepare to speak with their doctor, helping them prepare to define their own risk. How do you really do that? We've seen a lot of, theoretical information about it, but when it got down to the focus groups and really beginning to understand what people were thinking, what people were feeling, which is a big reflection of what Judy has already talked about, just really varied in terms of concerns, in terms of, anger was a big deal. This is, 3 years later, but people are still thinking, why? Why haven't we heard about this? The suspicions of the side effects and so on. I will not rehash that except to say that it was repeated over and over, and it became really important that we needed to understand how we were going to frame our education message as well as the messaging material, because some of the people that we work with are people that can barely read or are not on, do not read the newspaper. Often they listen to the news on radio, they listen to the radio, but they will not necessarily buy a newspaper or a magazine where a lot of PrEP information has been put. And even when they do that, how do you communicate some of the information that is in there to a level where, your population is going to understand it. Your population is not going to feel judged, and your population is going to begin to be accepting of the information that you're giving. We did the focus groups in conjunction with Black Women's Health Imperative. Octane actually works with HASA to do some of their marketing materials, and we've also been doing some ongoing work with George Washington University. But it was really interesting to hear, for example, one of the things that you said in terms of the discrepancies between older and younger women. The older women actually felt taking PrEP every day would not be an issue because they see taking PrEP every day and also going back for medical tests and seeing a doctor every 3 months, they felt that that wouldn't be an issue because they already do that from some of the other issues that they face. They go back to the doctors for, high blood pressure or diabetes, and they get prescriptions refilled every 3 months. The issue there was how it would interact with some of the existing conditions that they already have. The younger women, on the other hand, just had a lot going on. When we talked to them, too, about communication messages, and we had been thinking of Facebook and social media, and they were like, well, that's more old school. We're like doing Instagram now, and so on and so forth. Just filtering through how this information would not only be communicated in terms of education, but also in terms of adherence. Would you call them? Would you text them? Would this be more like case management, the way it is done with HIV-positive people? And really that is where we actually ended up landing. When Charlene talked about the guidelines, the heterosexual women, the fact that you have more than one partner, multiple partners, and seeding through that in terms of perception of risk, we realized that, you really almost need to have more enhanced guidelines or, on how to talk to people in terms of communicating, A, that they can define their risk, and B, how to communicate this with their provider. Because, again, I think this has already been mentioned, they don't want to tell the provider that they're doing some of this activity. They feel like they're going to be embarrassed. They feel like they're going to be judged. And so we are literally still working on, sort of that intake form, the preparation for the referral. What does the client need to take with them to the provider, the information that they need, and how they communicate that risk, I think has become really, really critical. And then in our case, our population, our target population, is dealing with a lot of trauma. Some of it may be childhood trauma. Some of it may be current trauma related to violence. There's mental health issues. And how do you weave through all of that to ensure that a person can manage their PrEP in the current situations that they're in, and how do they get the kind of support? And then there was also the marketing material. We had a lot of women, after coming to their focus group, drag in some of their children and asking us, 13-year-old, would they be eligible for PrEP because my 13-year-old needs it. And so how do we have education and marketing material for that population, as well as trying to find providers who would be willing to look at those situations case by case. In coordination with Black Women's Health Imperative, I'm just going to skip to, I thought I had a slide in there that showed the marketing materials that we had, but a little bit about our infrastructure. We already have testing, integrated testing that is funded by CDC. So PrEP was integrated into all of the screening and counseling that is done by our outreach, navigation workers. And then also we created referral forms for high-risk individuals so that they can be prescribed, they can be prepared for PrEP prescription. We also have developed the screening and intake forms. I think it's a big deal that we have a prevention case manager on staff who is working on developing an acuity scale for people that are at high risk for HIV and how that relates to PrEP. There's a PrEP education so that case managers and every staff member knows, what they say before and after the PrEP education. And we have, educated that many people so far. And I think it's really great that it's being integrated into all our services. And like I mentioned, we, in coordination with Black Women's Health Imperative, we were able to have access to marketing materials for heterosexual couples, for women, and, for younger women. And so they're able to have marketing materials of people that look like them, because I know that was an issue that came up. So I think I'm going to close with this point, which is really critical for us, is the fact that in our population, our target population, low-income women of color, these women are experiencing the same barriers in terms of access to care and adherence as, HIV-positive women have faced over the years. and through our prevention case management. So traditionally, we've tested people, they test negative, they go away, and we wait for them to either come back positive or hopefully come back and get another test and be negative. But with our prevention case managers, we're now developing prevention plans that help monitor these people and help them have goals in order to stay negative and possibly get on PrEP. PrEP is, we communicate that it's only one tool out of a larger prevention toolbox. But I think the issue has been the kind of support that they need, both as they're high-risk negative or especially when they provide PrEP. They too need transportation. They too need childcare. They too need food. They too need social service and emergency financial assistance. They also need treatment adherence and mental health support. And I think it's going to be important as people think about prescribing PrEP, especially for low-income women of color, that they are going to need as much support to stay adherent, just in the same way as HIV-positive women in the same kind of socioeconomic status have needed. And so, we're happy to share the information and marketing materials that we have, as well as some of the forms and things that we have, tools that we have been preparing to be able to counsel people around PrEP, and also we're able to continue to give education to various groups in terms of just prevention case management and PrEP. Thank you so much for your attention.
Great. Thank you so much, Martha. That is really amazing, and it's a great model for organizations in terms of how they can integrate PrEP into their services. So there's been some questions that you mentioned that you would be happy to share those materials, and so we'll provide links to the Women's Collective, but you can also share anything you want with us, and we can put it all on the one page with the webinar recording if you'd like. So we will definitely make those available. Okay, so I know we're running out of time. So we have quite a few questions. This is just a quick slide. This will be available on our website, but the WELL Project does have some fact sheets related to these topics, and these will also be available on our website. Some other additional resources of some great organizations and work that also cover PrEP, and we'll add others that have come up through this webinar in the chat, in addition to these resources on our website. And this is just a quick plug. This is on our website as well. We're conducting an annual survey right now, so any feedback you can provide in relationship to our programs and webinars like this would be great if you have a few minutes. So I don't know if we're going to be able to get to all of the questions, but we'll at least try and get at least one question to each of the presenters, and then we'll get as many as we can in the time allotted. So I think the first question that we'll pose to Dr. Flash that came up is PrEP safe in pregnancy?
Hi, so that's a great question. Is PrEP safe in pregnancy? I would say yes, but with the caveat that that's extrapolated data. We have data on hundreds of women who have utilized Truvada, the medication FDA approved as PrEP at present, during pregnancy. And these are HIV-positive women who've utilized this medication to as part of their full HIV treatment cocktail to prevent transmission to their unborn fetuses. And that data is being extrapolated to HIV-negative women. We do prescribe to women in the setting of desired conception, finding that any potential risk that may be there from not having this particular population have detailed exploration in the United States is offset by making sure that these women don't get infected and that they're able to bear children safely.
Okay, great. Thank you. So, and the next question I will ask to Judy that came in is what specifically about HIV-positive women's experience with ARVs makes them more pessimistic about PrEP? Adherence or side effects? Can you expound a little bit more about that?
Yeah, I'm sorry if I wasn't clear. It was predominantly the side effects, to some degree adherence, but it was the side effects, which, nausea, headache, some discomfort, and concern about bone loss was expressed about Truvada early on, the data are suggesting there's a lot less to worry about than people thought. But for the positive women, it was predominantly their own experience of taking drugs that produced unwelcome side effects over time.
Okay, thank you very much for that. And Martha, someone asked how are the prevention case managers being funded? Can you maybe talk a little bit about that?
Well, we have incorporated the position under our CDC funding, which requires navigation for high-risk negative people. And so that is, part of what our prevention case manager would do. And then also part of it was under the funding that we did receive from HASA, which is about the education. And so obviously we target more or less HIV positive people with our Ryan White funding. And so it was important to have someone who could specifically do a bit more further education for people that would be interested in PrEP. So we worked it under our education grant to be able to have that position. So it's being funded sort of from several sources, but I think it's with the idea that we are both educating and navigating people, high-risk negative people, to get PrEP.
Krista, this is Judy. May I add one thing to what Martha just said, real quick?
Sure.
Yeah, just as another example, which I did not mention because it is focused on gay men in San Francisco, that the Magnet program, now part of STRET, which is the San Francisco AIDS Foundation program in the Castro district of San Francisco, predominantly gay district, has embarked on a PrEP program that is nurse-led. So it's that's unique in that regard. And as Martha was describing, has sort of client navigators that includes not just health navigation between the STRET Magnet program and healthcare providers, but also all around benefits that are required and services that are required to support a person taking PrEP. So in this town, the big issue is housing and housing stability or instability and cost, but also other social services related to drug use or addiction, mental health issues, and so on. So I think a combination of case manager and navigator benefits as well as medical services navigators is really important.
Yes, I agree.
Great, thank you. And we'll try and sneak a couple more in if people have to leave, or I don't know, do our presenters have like a couple more minutes to answer a few more questions, or do you need to drop off? I know we're just at 1:30.
I'm okay for a few more minutes.
Okay.
I'm okay for a few more minutes.
Okay, great. Well, so I think, Dr. Flash, this next one is mainly in your wheelhouse. Is someone was asking about use of oral PrEP and drug interactions or possible drug interactions with oral contraceptives or the pill.
That's a great question. There are very few drug interactions between PrEP, the current formulation in PrEP, and other medications. However, there are medications where there are overlapping side effect profiles. For example, medications that might also put undue pressure on the kidney, where you would want to be aware that the person was also taking that additional medication to ensure that they're not having multiple medications with a similar side effect profile, making it more likely for them to experience that side effect. But PrEP really has very few side effects, and it is safe for use with birth control.
Great, thank you. And you mentioned kidneys, and so I'll just quickly ask about, someone had asked a question about the effect of Truvada on kidneys and in relationship to PrEP.
Right. So, we have data from HIV positive patients that a proportion of people that are on Truvada over time can develop some kidney dysfunction and develop what's a Fanconi syndrome, where they start spilling things in their urine that they should really be holding on to, so like protein, glucose, phosphate, things like that. What we found is that it seems to happen in a very small proportion of women, HIV-negative women, who are using this medication for purposes of PrEP. It is one of the reasons, though, that it's important for people to have appropriate medical follow-up we usually see our patients within a month after the initial prescription just to follow up that kidney function. And then for people who have no other medical problems, we follow up again in 6 months. If I have a patient, however, who has already something else that's giving them additional risk factors, like they have only poorly controlled blood pressure, or they have uncontrolled diabetes, or things of that nature, I see them every 3 months to make sure, because those women are more likely to have effects on end organ damage and having kidney effects on someone else, so they bear closer monitoring. Your clinician should notice any kidney dysfunction before the patient does. I've never had a person come in and say, oh, they had a urinary problem. I always notice it with the lab work first. And that's if you have a good partnership with your provider, that's how it should happen.
Okay, great. Thank you so much. And I think in closing, I think, something that was mentioned throughout the presentations today, and kind of a main reason why we were trying to target healthcare providers through the presentation today is the WELL Project does a lot of education on the community level around awareness and education around PrEP, but we hear often from the community that even when people are, aware and go and speak to their provider, the providers actually, sometimes brush them off or say, oh, this is not, and so what we're hearing from you, Dr. Auerbach, and Martha, about people being angry that their providers aren't talking. I mean, we also had a comment that this is happening. There's not a lot of primary care physicians prescribing PrEP. So I think if there's a takeaway about how do we reach into these other provider populations and networks, and what we can do to improve that awareness and education building, if there's any comments around that to leave us with. If you have any ideas.
Yeah, well, one of the things that has been coming up is that, the PrEP education somehow needs to be included in whatever continuing education that providers get. In fact, one way that we had wanted to do this education is, provide, work with an organization that could provide continuing education credits. I mean, it's, it really just has to be done at that higher level. Our clients can go there, and talk to providers all they can, but until it is streamlined in either, provider continuing education or provider forums, I just, and someone invests in that, I'm not sure, how else it can be done.
One other thing is that patients can feel empowered to inspire their providers to get this education. As a provider, there's so many things that we have to stay on top of, and so you are led to prioritize the things that you seek continuing education on. In a survey of our local providers, we found that even though only 18% had received an inquiry for PrEP from a patient, almost 90% of those providers said that if someone asked them about it and they didn't know, they would do the due diligence to figure it out and to try to direct that patient in the appropriate direction. And so I think it's a push and a pull that the patients can be empowered as well to inspire their providers to get that added information.
Right, and this is Judy. That's exactly what we were hearing from our focus groups as well. And I think the WELL Project, I know, is engaged in a lot of treatment/PrEP education and advocacy and literacy among women, so that women can become educated advocates on their own behalf and on behalf of all of their sisters. So I think we need to see a lot more of that as well. And that education includes not just peers, but, as Charlene was saying, friendly providers.
Absolutely, and our women are, where once we have the education, we've really been encouraged. Especially, I think one of the things that I wanted to add to when Dr. Charlene was speaking about the side effects is that what we understand is those actually disappear if you stop taking PrEP, or at least they reverse to some extent. And that comforted a lot of the clients. But I think a lot of the women that we've been speaking to are really empowered to go back to their doctors, as well as in working with the navigators, to be able to go back and ask for PrEP.
Great. Well, thank you so much. I think as we're getting a lot of positive feedback, and we hope to be able to share this even more widely with people that weren't able to attend the webinar by providing the recording on our website, as well as we'll be providing a PDF version of the slides and a bunch of other resources. Everyone who's attending this webinar, as well as those who registered and anyone that can access our website, will receive a notification when that's available in the next 2 to 3 days. And again, I would just like to thank everyone. There's a quote that was just posted, and I think it's a good a good quote to end on that is attributed to you, Dr. Flash. Is that correct?
Yes, ma'am.
Okay. It says, "We wear white coats as clinicians, not black robes as judges." And I think that's a great way to end our webinar today, and work together both on the community level, advocacy and education, as well as trying to build awareness on the provider and decrease any judgment or stigma around HIV prevention and HIV in general, and work together. So thanks to everyone, and we hope to see you all in future webinars.
Thank you so much.
Thanks, everybody. Bye.
Bye. Thank you very much to our presenters. You did a fantastic job.